Hi, my name's Alan Prost, and I'm a respiratory therapist here at SAIT. I'm an instructor, and I did some work preparing for the CSRT conference, the 2012 in Vancouver at the symposium. This is highlighting some of my slides and some of the work I did with the ASL 5000 test lung looking at pressure volume loops. So bear with me, and I'll go through some of those slides with you. So here's my basic Um, title, Development of a Reliable Ventilator Methodology to Display Neonatal Pressure Volume Loops Using a Simulated Lung Model. And as I said, I use the ASL 5000 for that. So here's what I did. I basically created a neonatal model that replicates the upper and lower inflection points on the ASL, and we'll see that in some tables and slides that I've got here. Then I ventilated this using the Servo-I ventilator, and I used a wide variety of settings just to see how easy it was and what the most accurate way to view those inflection points is. So here's the ASL 5000 ventilator and the computer that I used, just a laptop computer that gives us the information and controls the ASL 5000. So we actually build the test lung simulation on the computer, and that's driven right here by the ASL 5000. Now what you can't see is in behind here there's a little cylinder that moves in and out, replicating either spontaneous breathing by the patient or a standard lung simulation just like we have now. So I hooked that up to a Servo-I ventilator using a normal neonatal circuit, and I used a 3.5 neonatal endotracheal tube to ventilate the ASL test lung. So that's the basic setup. The software is intuitive to use and is very, very precise, and that's one of the things we discovered by doing this kind of simulation is that we can create pretty interesting lung models. All right, so in this slide, I'm showing you here the ASL lung model as we'd see it on the computer screen. And you can see I've programmed in here a very simplistic model with a lower and upper inflection point and very linear compliances in between those. So I've set up a lower zone of poor compliance, a mid zone of good compliance, and an upper zone of a lower compliance again, mimicking what we think a neonatal model should look like. So here's my neonatal model plotted on a graph, and this is what we set up with the ASL. So you can see I've got my upper and lower inflection points, and this is the calculated compliance from the model. Now I would expect this to be a little bit different because the ASL uses a two-lung model, so the compliance measured outside the system probably should have been twice this. But you'll notice when I tested it using this syringe method where I injected a known volume of air, 1 ml intervals, and actually measured the pressure, I got a rather different compliance graph. And I think that's different because of two main reasons. One, this double test lung model that's built into the ASL software. And secondly, it takes about 60 seconds for me to derive the pressures on this curve. And I think what happens there is that there's a leak. In fact, I know there's a leak about 2 to 3 centimeters of water pressure over a about 60-second interval in the ASL. So this adjusted and affected the compliance values, but what's really interesting is it did not change or affect the inflection points. So they were very precise still. And as you'll see in some of the other graphs, even though this compliance as measured by the syringe is a little bit different, we actually get quite accurate compliances and as we'd expect them to see them on the ASL neonatal model as interpreted by the ventilator. So let's take a little look at that. So when I initially was ventilating the ASL model, I set up 3 modes of ventilation: volume control, pressure control, and pressure control adaptive. And I set these all up to be about the same. So I had a tidal volume of 5 mils, I had a TI of 0.3 seconds, a short TI rise that defaults on the Servo-I of 1.5 seconds. All right. So in pressure control mode, I had to set up a pressure control level about 6 to give me a tidal volume about 4.8 mils. So they're all pretty similar. Now, on the actual model itself, the ASL lung simulation, I had determined and had set this up to have an inflection point of 3.5 for the lower part and an upper inflection point of 8. And I think that would plot out to about here. And you can't see at this on any of these where the inflection point would be in any of the modes. So what this suggests is in kind of our normal ventilator settings, you can't see the inflection points accurately. Now the overall average compliance, if you just kind of measured it through here, would be very equivalent on all of them, as I am going to show you on some other slides later on. But the subtleties of the and the nuances of the compliance and inflection points is lost on these settings. So here what I've done is I kept the same basic modes. I had volume control, and now I'm just going to narrow it down to just pressure control CMV adaptive because its waveforms and delivery is very similar to pressure control. And when I extended out the TI to 1.2 seconds, this gives me a really, really low flow rate as indicated on our flow volume loop right here. You can see I've got that very, very low inspiratory flow. This allows the inflection point to be more clearly delineated on the pressure volume loop. And in fact, if I measure the compliance of these lower zone and this mid zone in here, it actually reflects quite closely to my predicted ASL compliances that I measured on the ASL through the model and using the syringe technique. So that's quite close, I think. The inflection points are reasonable. On this model here, the ASL lung model 1, I still have this set at 3.5 centimeters for the lower inflection point of water pressure and 10 centimeters for the upper inflection point. And you notice on the pressure control, even with the longer TI, you still cannot distinguish any compliance values, or you can't see any of the inflection points on there. And I think that's because of this high inspiratory flow rate, and the resistance through the endotracheal tube masks any of those subtle measurements that could be measured on the flow volume loop. I think that the average compliance is quite comparable. A compliance of 1 to 1.2, the differences in that is quite subtle, and I think that's pretty realistic estimation of the actual average compliance of the lungs. The next thing I did was I created a more realistic scenario for the neonatal intensive care unit using slightly larger tidal volumes, and I kept a TI of about 1.2 seconds. Now my flow rate is about half a liter per minute. Right now I've got the PEEP on the ventilator set at 0. And in this test model, I should have an inflection point, a lower inflection point at about 5.5 centimeters of water pressure. And my upper inflection point was again at about 10 centimeters of water pressure. All right. So you can see here with the low flow volume technique, I can actually draw the transects and see this lower inflection point, and it seems to be pretty accurate compared to that ASL model. The compliance values here seem to be close to what I would have predicted with my ASL model. And we've got our average compliance. So this looks pretty realistic to me, and I do get to pick out that accurate inflection point. At least it looks to be so from the data that I have. So this is a detailed blow up of what you see actually on the ventilator. What I did next was I took this a little bit further and I did a little bit of a PEEP study comparing volume control, just like you saw in the last graph, compared to the pressure control CMV adaptive. So I set them both up to have very similar tidal volumes, similar TIs, similar TI rises. And what we can see here is this is taken right off the ventilator, photograph right off the ventilator. I can pick out the lower inflection point quite clearly, where in the pressure control mode, we can't see the inflection point. I think that the average compliance as measured in both methods is quite accurate. All right, but here we can get a little better idea of what that compliance values are for the lower and in that better zone in here. So as I up the PEEP level, now I've gone up to a PEEP of 2, overall average compliance improves just like I'd expect, so that's improved. And we see them very similarly on both and quite an accurate number. And of course, less of that lower zone is now part of that ventilatory cycle. So I've improved things a little bit for the patient. I'm overall ventilating a little bit more into that more compliant zone, but still we should probably increase the PEEP some more. So in this next study, I increased the PEEP to 4 centimeters of water pressure. And you can see I can still see part of that lower inflection point right here. And I've got my overall average compliance now is quite close to what I'd expect for ventilating in that most compliant zone. So this looks like quite an improvement. And whether I was in pressure control or volume control, I can see that improved compliance in both of these models. But in pressure control, I can't see that lower inflection point. So if I didn't know about that lower inflection point there, sorry about that. If I didn't see that lower inflection point from this model, I wouldn't know about that in pressure control. So the next logical step would be to increase the PEEP to 6. So now I'm above my lower inflection point. I can't see that any longer in volume control, but what I've done is I've accidentally started to overinflate the lungs, and I'm starting to see that upper inflection point related here. Now, in pressure control, I can also see some evidence of that upper inflection point right in here. So because the flow at the end of inspiration in pressure control, as the pressures in the circuit of the ventilator and the pressures in the lungs become close to the same, flow rates are really low and resistance is less of a factor. That's why I think we can potentially see those upper inflection points. Unfortunately, this is not always true, as I'll show you in some other slides, but it may be true when you can see it like this. All right, so here's an overlay of volume control and my pressure control adaptive again, but in this case I've used quite large tidal volumes, and I just overlaid them so you can see the difference between the volume control volume pressure waveform loop and the pressure control volume pressure loop. What's interesting and important to note about this is that, of course, in the volume control, I can see these inflection points, but you notice they're not very sharp. They're kind of soft, and this is a very similar model to what you had just seen. It's a little bit hard to define exactly where those inflection points are, and I think that's because I've got this relatively higher flow rate of about 1.1 liter per minute. It was because of this information that I decided that it might be best to keep my flow rates less than 1 liter per minute for doing these kinds of studies. You notice in pressure control I get no idea of what the inflection points are, so it really doesn't help me with determining potentially the optimal PEEP. Another thing about this graph that I wanted to point out for you is in the flow volume loops. Of course, we can see the difference on inspiration. Pressure control, of course, initially having this high flow rate and is slowly decelerating down to near zero as volumes become equivalent at the mouth and in the circuit. And of course, in volume control, it's maintained at this relatively low flow rate throughout inspiration. But it's the expiratory waveforms I wanted you to see that are very similar on both of these. In fact, it's almost the inverse of the inspiratory one. And they're the same. Because the expiratory waveform has these higher flow rates here, I'm making the conclusion that we cannot see any inflection points or getting any information on this expiratory side of the flow volume loop. And that's important because there are some authors out there that are suggesting that we should be looking at this expiratory side of the flow volume loop. But I suspect what they're doing is they're using the syringe method to examine this part of the upper curve and not a ventilator. All right, because in a ventilator we can't limit the effects of flow and resistance, so we're seeing all of those combined, and that's really masking the actual lung characteristics that we're looking for. So I suspect that we really cannot see any information about the lung characteristics on the expiratory side of the curve here when using a ventilator to generate the volume pressure curves. But if we use a syringe technique, we may be able to do that. So that's my suppositions. If you'd like to see a more detailed look at these graphs in more detail, you can go to a website or a download from Dropbox that I'll give you in just a minute. So to accurately view lung characteristics, you got to use low flow volume techniques, in my opinion. Um, it may be possible to identify upper inflection points in both the volume control and pressure control, but you're going to have to be careful because sometimes it may be masked in pressure control. It depends on the tidal volume and the flow rates. I don't think that we can see any accurate lung characteristic information on the expiratory side of the pressure volume loop. I think that we can use these techniques to adjust PEEP, and we may be able to do that in volume control or pressure control, looking at that average lung compliance. But I'm going to suggest that we should use volume control to make sure that we're not either still having a lower inflection point or actually be up over our inflection point, as I showed in my PEEP study in diagram 7. So another aspect of this, to be able to do it accurately, I think we need to get the manufacturers to allow us to easily remove and pull off these pressure volume loops at the bedside and print them up and be able to draw on them and compare them as the patient's either condition changes over time, and it might get worse or improve, so we can continuously see where we've been and what we're chasing down with these pressure volume loops. So my name's Alan Prost, and that's my data that I have here for you today. Here's some references like I said, I am going to supply these slides, make them available as an interactive PDF to anybody who'd want them. All right. I'd like to acknowledge Meena Kumar, my academic chair, for giving me the opportunity to present this information, and my dean, Dr. Alan Billy, who also supports me to do this little bit of research and to go to things like the CSRT. So here's my interactive PDF Dropbox address that you can link to, and if you click on this, you'll be able to get my interactive PDF and look at those graphs and the diagrams in detail, and also be able to contact me at alanprost@sate.ca. So I hope to hear from you if you have any comments about this video. Thank you very much.